The key differentiator between cerebral salt wasting and SIADH clinically is the estimation of volume status. If the patient is hypovolemic and continues to lose salt in the urine, then it tends favoring a diagnosis of cerebral salt wasting. When we look at the treatment options between cerebral salt wasting and SIADH, firstly, in cerebral salt wasting, you're basically losing both salt and water. So you have to replace both these. So you need to have a way of replenishing salt, and you have to have a way of holding back the salt that you give them exogenously. If you give them extra salt, they will pee it out. In the setting of salt wasting, that's where the role of mineralocorticoids come in. By adding mineralocorticoids to the sodium replacement, you're able to hold the salt back in the system. That's one of the key management principles. On the setting of SIDH, because there is too much ADH, you're retaining too much free water and you're diluting out whatever's in the system. So that's how you get a dilutional hyponatremia. So your treatment revolves around getting rid of the extra free water and not adding any more to the system. So that means you're going to restrict the free water that the patient gets in a 24-hour period, and you're going to add drugs such as the Vaptans, like the Conivaptan and the Torvaptan, to help get rid of the extra free water in these cases. In cerebral salt wasting, basically the salt and water are wasted by the kidneys. So you're going to have ongoing intravascular fluid depletion. The treatment is to replace the intravascular volume loss along with salt. So you have to have a mechanism by holding back the salt, and that's where the mineralocorticoids come in. In SIADH, there's too much ADH that causes too much free water retention, and you get a dilutional hyponatremia essentially. So the treatment is centered around losing this extra free water and restricting excess input.